Good morning, everybody. My name is Teresa Karsten. I serve as the Deputy Administrator over Managed Care, Quality Assurance, Access to Healthcare, and Medical, Dental, and Behavioral Health Benefit Coverage. Today, I'll be presenting on the state's efforts to expand the Managed Care Delivery Program statewide. And here are some of the items we're going to touch on today in our agenda. Go ahead and get started. In Nevada Medicaid, there are two delivery systems, one referred to as fee-for-service and the other as managed care. In the fee-for-service delivery system, the state agency administers the benefits directly through a delegated vendor. The state pays providers directly for services rendered based on rates set for each service and funded by the state legislature. Currently, about 28% of the Medicaid enrollees receive services from this delivery model, and that includes waiver recipients that are aged, blind, or disabled, and all residing in rural and frontier Nevada counties. The managed care delivery system is administered by awarded managed care vendors selected in the state's procurement process. These vendors are responsible for developing networks and paying providers for member care. MCOs are responsible for contracting and negotiating rates with the providers within their networks. The state pays each MCO a per member per month capitated rate, and MCOs are responsible for paying for the services rendered by providers. MCOs have the authority to negotiate fee-for-service reimbursements for each service, or they can enter into alternative payment arrangements for vendors such as capitated payments, etc. Currently, 72% of Medicaid members are assigned to one of our 4 MCOs in urban Washoe and Clark counties. Managed care is mandated for the residents of these counties that are either children, parents, or adults without children. The only voluntary population in managed care that have an option to opt out are American Indian, Alaskan Natives, children with special health care needs that are receiving Title V funding, and children with a seriously emotionally disturbed determination. Nevada has had managed care delivery model since 1998, when Nevada awarded 2 MCOs to provide services in Washoe and Clark counties. The state has a choice on what services they contract the managed care entity to cover. Some benefits are identified as carved out of managed care, and that means the state does not pay the MCO to provide through the MCO network those services to the MCO members that have been assigned to their caseload. Medicaid members still have access to those services, but they are authorized and paid for by the fee-for-service delivery system. In January of 2022, the division awarded 4 MCOs contracts for coverage in 2 urban areas of Washoe and Clark counties. The current 4 vendors are Anthem Blue Cross Blue Shield, Molina Healthcare, Silver Summit Health Plan, and Health Plan of Nevada. In Nevada, we re-procure MCO contracts every 4 to 5 years in alignment with state purchasing laws. Our new awarded vendors will be responsible for member care effective January 1st, 2026. The Nevada legislature authorized the expansion of managed care delivery systems statewide in the last legislative session. Approximately 75,000 children, parents, and adults without children who live in rural and frontier Nevada counties will now be covered by a managed care entity. 126,000 Medicaid members will remain eligible for services through our fee-for-service delivery system, and those individuals are children in our Katie Beckett program, children that are in foster care, individuals with disabilities, seniors, and members receiving our waiver program services. Vendors bidding for the MCO RFP by law are required to have a good faith effort bid to offer a public option plan under our Silver State Health Insurance Exchange beginning plan year 2026. The division finds stakeholder input of great value prior developing and posting any RFP for Medicaid services. So beginning in the fall of 2023, Medicaid staff met with hospitals in rural and frontier Nevada counties. Then we later published a request for information that yielded 30 responses. And then beginning in 2024, the division hosted 2 public workshops related to policy and operations that we would like to further expand and clarify in our RFP for calendar year 2026 services. Here are some of the key DHHS priority areas we focused on that were also highlighted as important to address for our stakeholders. Service area expansion, access to care, member and provider experience, quality and outcomes, and better population health. In 2026, Medicaid MCOs will provide services in 3 geographic areas: urban Clark County, urban Washoe County, and the remaining rural counties. Contracts may be awarded to vendors to cover 1, 2, or all 3 service areas in the state of Nevada. In order to support better access to care, the division has added new network adequacy requirements. Pending CMS approval, we also intend to expand telehealth coverage. And then this contract will require MCOs to award the rural service areas, or those MCOs awarded the rural service areas to cover the non-emergency medical transportation benefit, which assists members to getting to their medical, dental, and behavioral health appointments. Some additional new policies we included to address access to care would be for MCOs to submit plans to improve access in their awarded coverage areas and report on their performance. And finally, after meeting with providers and receiving recommendations from our request for information, the division also decided to implement a universal rate floor, which will require the MCOs to reimburse no less than the fee-for-service fee schedule for all provider types. In an effort to improve both member and provider experiences, the division revised policies to facilitate transitions between MCOs for members and attempted to reduce some administrative burden for the providers. MCOs will be required to honor medications, prior authorizations from other vendors, and pay for services being received from out-of-network providers for a minimum of 90 days after the transition into a new managed care entity. Case managers assigned to serve the high-risk case management population will be required to have specific training for prenatal and postpartum care. And in order to reduce provider burden, the division is requiring MCOs to follow established standards for prior authorization forms across all plans and our fee-for-service vendor Gainwell. Our goal is to reduce the number of forms that are required for each of the services. For care quality and outcomes, we reviewed the systems of care in place for specific populations and services and are requiring the following. We're ensuring MCOs partner with local community-based organizations to ensure maternal and child services are addressed from a health promotion and education lens. The MCOs must establish policies and procedures within their network providers that offer same-day co-located primary and behavioral health services, and also requiring MCOs to participate in our newly established Nevada Hospital Quality Collaborative, which explores value-based purchasing options for hospital payments in order to improve health outcomes of the patients served at each of the hospitals. And finally, MCOs will use the division's uniform preferred drug list and cover drugs as outlined in our Medicaid services manual. Population health efforts will focus on the following new criteria: MCOs will conduct annual follow-up health needs assessments for individuals that are not engaged in active case management. MCOs will have the option to cover housing and nutrition supports for homeless individuals or those at risk of homelessness under the in lieu of service option. MCOs will be required to invest in the improving health. MCOs will be required to invest in improving health within their communities by contributing no less than 3.5% of annual profits to activities that will improve overall health outcomes. Under federal law, MCOs are allowed to provide value-added services, which are services that are not reimbursed by Medicaid and are directly funded by the MCOs. The division is encouraging MCOs to target the following areas for value-added services, those being home visiting programs for high-risk pregnant members, child care subsidies, and remote patient monitoring. Finally, as Nevada prepares for our 1115 demonstration waiver application for pre-release services, the division will likely require the MCOs to support the transition of incarcerated individuals into the community and assist them with their healthcare needs and ensure they have access to necessary medications upon release. As of today's recording, the RFP has not been posted. Dates outlined in this slide are subject to change, and all dates outlined in the posted RFP are final. If you have questions pertaining to the RFP, the contact at Nevada Purchasing is Ryan Bradenberg, and his contact information will be outlined on the solicitation page. We expect that the RFP will likely be posted on October 15th or near that date. And as I mentioned, all finalized RFP dates will be in that posted RFP. I thank you for watching this presentation. DHCFP can be contacted at the posted email, but please note that we are very limited in what staff can discuss regarding the RFP, the associated documents, and any other related procurement details. We will likely direct your inquiries back to Nevada Purchasing, but we are happy to assist in any way possible. We thank you for participating in this presentation and have a great day.